Yeah, good evening. So I'll be showing few OSCEs in hepatobiliary system. I'd like to thank our HOD, Dr. Devinal ma'am, and our professor, Dr. Gopinathan sir, for giving this wonderful opportunity. So this is the first case. So it's a 2-month-old infant presented with jaundice and hepatomegaly. So I've given you a few ultrasound and Doppler images. So what is the diagnosis? So what is this first image? What is it showing? Yes, this triangular cord sign. What is it? It is echogenic linear band anterior to portal vein, which represents remnant ductal tissue. And what is the second image showing? So what is the structure? This is gallbladder, this atretic gallbladder, and this Doppler, there is increased subcapsular hepatic arterial flow. So these are the classical features of biliary atresia and ultrasound. So what are the important diagnostic findings? How do you classify and manage, and what are the anomalies associated with this? So as I already showed you, typical ultrasound features are triangular cord sign. Then there is gallbladder ghost triad, which includes atretic gallbladder with length less than 19 mm with irregular lobular contour and lack of smooth echogenic mucosal lining. And there is also increased subcapsular hepatic arterial flow with dilated hepatic artery measuring more than 2 mm at porta hepatis. So it is classified by CASA into 3 types. So in type 1, there is obliteration of only these common bile duct portion. In type 2A, there is obliteration of only the CHD. Whereas in type 2B, there is obliteration of entire common duct and cystic duct. And in type 3, there is obliteration of right and left main hepatic ducts also. So the most common type is type 3, which is in more than 90% of the cases. It is managed by Kasai pontoantrostomy and or by liver transplantation. So the most common indication for liver transplantation in childhood is biliary atresia, please remember. And what are the anomalies associated with this? Maybe associated with polysplenia, asplenia, intestinal malrotation, hetotaxis syndrome, and interrupted IVC. So move on to the next case. So it's a 6-year-old girl who presented with abdominal pain, jaundice, and a palpable mass in right hypochondrium. So what is the diagnosis? What is the modality? So what is the technique used here? This is an MRCP image. So what are you able to see here? Forget about these structures, just see these structures here. So what are you able to see here? So there is diffuse cystic dilatation of the entire intrahepatic and extrahepatic bile ducts, and there is also anomalous pancreaticobiliary ductal union. The entire pancreatic duct is not seen here. So this junction is the anomalous pancreaticobiliary ductal union, and there is a long common channel here with some debris in the distal common channel. So it's a case of, what is this? 6-year-old girl. I've told you the findings. What is this? It's a case of colorectal cyst. So how do you classify and how do you manage this condition? It is classified with Todani into 5 types, where type 1 is fusiform dilatation of only the extrahepatic ducts, and type 2 there is a true diverticulum in CBD, and in type 3 there is a small diverticulum and the ampullary portion of CBD, that is also known as choledococele. Type 4 is divided into A and B. Type 4A is strictures with multicystic dilatation of both intrahepatic and extrahepatic ducts, and in type B there is multiple strictures with multicystic dilatation of only the extrahepatic duct. Type 5 also known as Caroli's disease, wherein there is multicystic dilatation of only intrahepatic ducts, which on CT shows, what is the sign on CT you see in Caroli's? A central dot sign with enhancing portal vein. So it is more than 90% or 80% of the case more commonly associated with abnormal pancreaticobiliary ductal union, as we saw in our case, with a long common channel measuring more than 1.5 centimeter. So management is by excision of all cyst tissue and reconstruction of the continuity between the liver and the gut. So move on to the next case. I have provided CT images with in arterial, portal venous, and delayed phase. What are you able to see here? There is an ill-defined, almost isodense to mildly enhancing peripheral enhancing lesion. Yes, it is a glass skin tumor. So it is present in at the confluence of right and left hepatic ducts, and on portal and delayed phases show gradual enhancement with dense enhancement in the delayed phase representing fibrosed component. So diagnosis, as you already discussed, glass skin tumor or hyalocholangiocarcinoma. So how do you classify? What is the most common classification system used for this? Yeah, bismuth correlate classification, good. So, according to this classification, type 1, there is involvement of CH common hepatic duct without extension into the confluence. In type 2, there is involvement of the confluence as well. In type 3, there is divided into A and B. In A, it extends from confluence to the right hepatic duct. In B, it extends into the left hepatic duct. Whereas type 4, it involves both right and left hepatic ducts. So, what is the limitation of this classification system? It does not take into account any vascular invasion or lymph node metastasis or distant metastasis. So, other classification staging systems which address these issues are the TNM staging by Memorial Sloan Kettering Cancer Center and by Radiology et al. The last two classification staging systems are not routinely used because it has not been proved in multi-center trials. And also the TNM staging has multiple limitations when used preoperatively. So therefore, bismuth correlate this classification is the one which is used preoperatively, and TNM classification is predominantly used for prognosis only. So what are the criteria for unresectability in hyalocholangiocarcinoma? You have to mention all these points because the surgeon will expect all these points. So what are the criteria? One is the bismuth, any bismuth type 4 tumor, and when there is invasion of the main portal vein or the proper hepatic artery, or when there is atrophy of one hepatic lobe with contralateral vascular invasion, when there is atrophy of one hepatic lobe with the contralateral tumor extension to the secondary biliary confluence, when there is invasion of secondary biliary confluence in one lobe and contralateral vascular invasion, and when there is metastasis to N2 lymph nodes or any para-aortic lymph nodes, or when there is distal metastasis. So all this should be mentioned in the report. Even if they are not present, you have to mention as negative findings. So the next case, is a 45-year-old man who presented with recurrent episodes of jaundice and cholangitis. So what do you see here? So what is this? This is a syndrome. What is the syndrome? Yes, this Mirrors syndrome. So what do you see here? There is a large hypointense calculus and cystic duct which is compressing the CBD common duct portion with proximal dilatation. So it's Mirrors syndrome. So what are the predisposing factors and classification system? So predisposing factors are low insertion of cystic duct and tortuous cystic duct. It is classified with Sanders into 4 types. In type 1, there is presence of calculus and cystic duct without formation of the fistula. It's just compressing the CBD. In type 2, there is a formation of fistula with CBD, that is cholecystocolidocal fistula, wherein less than 1/3 of the CBD is involved in the fistulous communication. In type 3, more than 2/3 of the CBD is involved in the fistulous communication, and type 4, almost the entire CBD is involved in the fistulous communication with the calculus cystic duct. So how do you manage? Its management is based predominantly on the classification by Sanders. So in type 1, where there is only cystic duct calculus present, so it is managed with simple cholecystectomy. In type 2, where there is less than 1/3 of the CBD is involved in the fistulous communication, the gallbladder is removed and the fistula is reconstructed using the remnant gallbladder wall, and the T-tube placed in the distal CBD. Whereas type 3 and type 4, where more than 2/3 of the CBD is involved in fistulous communication, it is managed by Roux-en-Y hepaticojejunostomy. There is no other treatment. Here, that is about Mirrors syndrome. So the next case is 55-year-old man who presented with intermittent abdominal pain and jaundice. So what you can see here, I have presented axial and coronal images CT. So what is this? What are you able to see here? So this is a diverticulum in the periampullary region. Yes? Yes, good, it's Lamel syndrome, excellent. So there is a periampullary diverticulum causing compression of the distal CBD with proximal dilatation causing obstructive jaundice. That is typical Lamel syndrome. So how do you manage this condition? So asymptomatic patients are managed conservatively, whereas symptomatic patients may be managed either by endoscopic retraction of the entrap material, or by extracorporeal shock or lithotripsy, or by laparoscopic diverticulectomy. So next case is a 70-year-old man who presented with abdominal pain. So what is the diagnosis here? Ultrasound images of gallbladder. So what is the diagnosis here in this case? Yes, good. It is acute gallbladder hydrops. So there is a calculus in the neck or cystic duct which is causing obstruction, and there is distension of the gallbladder lumen. But as you can see, there are even on compression, the rounded edge of the gallbladder is not lost. It's a case of acute hydrops. So signs of acute hydrops on ultrasound are direct demonstration of the impacted stone in gallbladder neck or cystic duct with hydrop sign. So that is non-compressibility of the gallbladder, which keeps its rounded shape on axial section. And there is large gallbladder distension, and ultrasound Murphy sign, that is pain on pressure over the gallbladder. So what is the further course of this condition? So about more than 60% of the cases, the stone which is obstructing the neck may get dislodged, and there may be some reperfusion of the reperfusion edema of the wall due to some ischemia, and it reverts back to normal. And about 25% of the cases, the stone remains in the neck, but there is some space for the bile to pass, and there is a perfusion of the wall, and it reverts back to normal. Whereas in about 15% of the cases, the stone stays in the neck and there is severe obstruction obstructing the passage of bile. So there is increased mucus production, there is increased intraluminal pressure, and there is ischemia of the wall. So progressively there is development of gallbladder wall thickening with increased pericholecystic inflammation and fluid collection, and it leads to cholecystitis. So in acute height drops, CRP will remain normal, whereas there will be leukocytosis clinically. But in cholecystitis, there will be elevated CRP. Patient will have more fever and increased pain. And in most of the acute height drops cases, patient will have some pain for over 1 or 2 weeks, and gradually he becomes normal. So it's about the gallbladder height drops. So next case, I provide ultrasound image of liver. There is a cystic lesion. What is this? Yes, this hepatic hydrated cyst. How do you classify this? There are two classifications, by Garbe and WHO classification. So by WHO classification, it is classified into CE1 to CE5. So CE1 and 2 are active lesions. In CE1, there is a univesicular cystic lesion, and in CE2 there is multisepted honeycomb cyst. CE3A and CE3B are transition phases, wherein CE3A there is presence of detached membranes with autolyl sign, and in CE3B there are multiple daughter vesicles in solid matrix. Next, CE4 and CE5 are inactive lesions, wherein in CE4 the cyst will have heterogeneous content within, which may be hyperechoic or hypoechoic. There is no presence of daughter vesicles, and in CE5 there will be calcification of the wall. Treatment is based predominantly on the classification. So how do you treat based on classification? So CE1 and CE3A lesions, wherein there will be univesicular cyst, and when there are detached membranes without daughter vesicles, it is treated based on the size of the cyst. If it is less than 5 cm, it is just managed by albendazole. If it is between 5 to 10 cm, it is predominantly just managed by PARE technique, that is puncture, aspiration, injection of scolicidal agent, and reaspiration along with albendazole. And this size is more than 10 cm, it is treated by Burkitt's techniques and albendazole. And when there is chronicization, that is if it goes to CE2 and CE3B, wherein there is presence of honeycomb cyst or daughter vesicles, again if it is less than 5 cm, it is managed by albendazole, whereas if it is more than 5 cm, it is considered for surgery with albendazole. And inactive lesions, that is CE4 and CE5, no treatment to be done, you can just wait and watch for it. So it's about hydrated cyst. The next case, so 35-year-old man who presented with abdominal pain and distension. So I provided axial and coronal CT images. So what is the diagnosis? So what are we able to see? What are the findings here? There is heterogeneous liver with some nutmeg appearance, and there is caudate lobe hypertrophy, as you can see here. Coronal section, what are you able to see here? There is occlusion of the intrahepatic IVC. So what is the diagnosis? Yes, good, Budd-Chiari syndrome. So there will be acute and chronic. So acute condition, what will be the imaging findings? So acute, there will be predominantly hepatomegaly, splenomegaly, and there will be some heterogeneous liver parenchyma. Whereas in chronic phases, chronic stage, there will be caudate lobe hypertrophy, large ascites, and on contrast enhancement. So there will be early enhancement of the central liver around the caudate lobe with the delayed enhancement of the periphery. So in delayed phases, there will be enhancement of the periphery with central hypoenhancement, which is known as flip-flop appearance. So that is in the acute and chronic phase. So how do you treat this? Acute Budd-Chiari syndrome, it is treated based on the age of the thrombus. Hyperacute thrombus is treated by pharmacological agents causing thrombolysis, whereas older thrombus are treated by mechanical thrombolysis. Whereas chronic Budd-Chiari syndrome, if there is a membranous or short segment occlusion of hepatic veins or IVC, it is treated by angioplasty. Chronic is predominantly due to fibrosis of the hepatic veins leading to inflammation. So, and if there is residual stenosis following balloon angioplasty, stenting may be required. And if hepatic veins are replaced by intrahepatic collaterals, it is managed by TIPS water strips. Yes, transtubular intrahepatic protostemic shunting. TIPS is predominantly done as a bridging therapy for liver transplantation, or when there is contraindication for liver transplantation in these cases. But definite treatment for Budd-Chiari syndrome is always liver transplantation. So as the next case, I provided you case A and B. So what is A, what is B? This is arterial and this is portal venous phase. So what is A, what is B? So what is A? What are you able to see here? This is an arterial phase. How is the enhancement? Yes, there is hyperenhancement, there is homogeneous enhancement of the periphery, whereas there is central hypodense area which is non-enhancing. In portal venous space, there is almost isogenation to the river parenchyma. So remember, there is homogeneous enhancement in the arterial phase here, whereas in this case, in B, how is the enhancement? There is heterogeneous lobular enhancement of the lesion. What do you see in the center? There is central calcifications with hypodense area which is non-enhancing in the arterial phase, whereas in portal venous phase again there is almost isogenation. So what is A? Yes, A is FNH, focal nodular hyperplasia, and B is fibrolaminal HCC. So what is FNH? Is it a tumor? No, it is a vascularization. Predominantly it is a hyperplastic response to increased blood flow in some cases of arterial malformations, whereas hepatocell fibrolaminal HCC, it is a malignant lesion. So how do you differentiate these lesions on imaging? This is important. So on arterial phase, the FNH will show homogeneous enhancement, whereas FLC shows heterogeneous enhancement. And calcification is a predominantly a feature of FLC. And on MRI, T2-weighted imaging is a very significant finding which leads to the differential in many of the cases. So on MRI, in T2-weighted imaging, the scar will be hyperintense in FNH due to the vascular scar, and in FLC it is hypointense scar due to fibrosis. And FNH will have Kupffer cells present since it is not a malignant lesion. There is Kupffer cells present, and so far there will be accumulation of supraparamagnetic ion oxide and hepatobiliary agents on imaging, whereas in FLC there will be no Kupffer cells, therefore there is no accumulation. And since FLC is a malignant lesion, there will be invasion of hepatic vessels or bile ducts and lymphadenopathy, whereas FNH you don't see these findings. So these are differences between FNH and FLC on imaging. So we go to the next case. So we provided T1, T2 weighted and CT images. There's another image here. So what is this? What is the diagnosis? So multiple irregular lobulated T1 and T2 hypointense lesions in both lobes of liver. So which on CT shows calcifications. So this image is not clear. It is irregular growth in the sigmoid colon, which is hyperintense on T2. So this is calcified liver metastasis with colonic sigmoid colon growth. Whenever you see calcified liver metastasis without a known primary, always first think of a mucin producing neoplasm from the GI tract. So that is the most common cause. So what are the other primaries? So it is most commonly seen in mucin producing neoplasms from GI tract, colon, stomach, and as well as breast. May also be seen in ovarian carcinoma with deposition of Sammomatous bodies, and melanoma, thyroid carcinoma, chondro or osteosarcoma, and pleural mesothelioma. So about calcified liver metastasis. So the next case, so I provided an MRCP image. So what is the diagnosis? What are the specific sign you are seeing on MRCP here? Yes, be loud. What is the diagnosis? Yes, it is pancreas divisum. Good. It is a case of classic pancreas divisum. So what is the sign you are seeing? What is the specific sign on MRCP you see? What is the sign known as? Yes, be loud. What is the sign here? Specific sign on MRCP. What is the name of the sign? It is a crossing duct sign, wherein the dominant dorsal duct is seen crossing over the intrapancreatic portion of the CBD. So it's a crossing duct sign, specific sign on MRCP. So it is divided into three types, wherein type 1 is a classic case with total non-union or non-communication between the ventral and dorsal ducts. In type 2, there is only the dominant dorsal duct without presence of ventral duct, so there is absent ventral duct, whereas in type 3, there is ventral duct present and there is a rudimentary communication between the dorsal and ventral ducts. So how do you manage this? It is managed by sphincterotomy or by papillary dilatation or by minor papillary stenting for decongestion of the dorsal duct. It's a case of pancreas divisum. So what are the technical modifications in MRCP? So one is secretin stimulated MRCP, wherein we give secretin intravenously to visualize the pancreatic duct, which causes increased secretion. So it is predominantly used for cases wherein we have to characterize the lesions of pancreatic duct, like anomalies or any strictures, or in case of any communication between the pancreatic duct and pseudosis, or in characterizing a pancreatic or sphincterophoric dysfunction. There's a functional MRCP wherein we give intravenous MR lipophilic paramagnetic agents, which are then excreted by the hepatobiliary system. And we also give negative oral contrast, which are rich in manganese, like pineapple or blueberry juice, which shortens the T2 relaxation time and null the signal from the duodenum on MRCP images. So these are the three more technical modifications in MRCP. Take down this. So as the last case, so what is A, B and C? All are MRCP images. So what is A, what is B and what is C? What is A? What are you able to see in A? Sorry? No, B load period I'm not able to hear. Yes, there is dilated, very dilated main pancreatic duct. In B, there is a cystic lesion along the encinate process neck with cluster of grape appearance, and it is communicating with the ventral duct here. And C, there is dilated pancreatic, main pancreatic duct with also presence of minor small cysts along the side branches. So A is, so all are case of IPMN as I showed. So what is A is main duct type of IPMN, B is side branch duct of IPMN, and C is mixed form wherein the presence of both main duct as well as side branch IPMN. So the other important thing in this IPMN is what is the international Fukuoka consensus guidelines or the Tanaka criteria for management. So management is very important in all radiological cases. We shouldn't just think about diagnosis, because only when we know the management we can give the proper points to the surgeons for managing the cases. So what are the Tanaka criteria for management of these lesions? So the features are divided into high risk features and worrisome features. So the high risk features in IPMN are presence of obstructive jaundice in a patient with cystic lesion head of pancreas, and MPD is dilated more than 10 mm, or when there is a hyper-enhancing neural nodule presence measuring more than 5 mm. These are the high risk stigmata. And other worrisome features are presence of clinical pancreatitis, cyst measuring equal to or more than 3 cm, thickened and enhancing cyst wall, and an MPD size is between 5 to 9 mm, or enhancing neural nodule less than 5 mm with presence of lymphadenopathy, or there is abrupt change in caliber of the pancreatic duct with distal pancreatic atrophy, when the cyst growth rate is more than 5 mm in 2 years in follow-up, or when there is elevated CA99. So it's the flow chart in the management. So if any of the high risk features are present, you can directly go for surgery if there is clinically appropriate conditions. Or if the high risk features are not present, you have to see for presence of any worrisome features. And if any of the worrisome features are present, then you can perform endoscopic ultrasound. And on endoscopic ultrasound, if you are able to see the definite neural nodule more than 5 mm or main duct features suspicious for involvement, then you can go for surgery again if clinically appropriate. And if any of the worrisome features or high risk stigmata is not seen, or even the endoscopy is negative, then you can, it is managed based on the size of the cyst, largest cyst. So if it is less than 1 centimeter, you can follow up with CT or MRI in 6 months, then after 2 years if there is no change. If it is between 1 to 2 centimeter, it is managed by CT and MRI, follow up 6 months and 1 year yearly, and 2 years, then lengthy interval up to 2 years to manage if no change. And it is between 2 to 3 centimeter, it is managed, it is followed up with endoscopic ultrasound 2 to 6 months, then lengthy interval up to 1 year, alternating MR and endoscopic ultrasound. Consider surgery in young fit patients and need for prolonged survival. If it is more than 3 centimeter, then close surveillance, alternating MRI with endoscopic ultrasound is done every 3 to 6 months, and strongly consider surgery in young fit patients. So it is in all the cases I would have shown the treatment options. So specifically you have to know the treatment, don't just stick on to the diagnosis part, always the management has to be known so that we can communicate properly with the clinicians. So thank you so much.
Thank you for the interesting and informative session, sir. I now request our Assistant Professor Dr. Arun Dilip sir to felicitate Akashkumar sir. For the last session,